of mostly inherited disorders in heme biosynthesis. It's a rare metabolic disorder which is caused by altered enzyme activity within the heme biosynthesis pathway. Altered enzyme activity in the heme biosynthesis pathway is usually due to a mutation in the gene responsible for that enzyme. In terms of classification, there are multiple classifications that exist, but the one that is relevant to us as anesthetists is the one that classifies porphyria into acute and non-acute porphyria. This is because in these patients, the main thing that we want to prevent is development of an acute porphyria crisis, which is also known as neurovisceral crisis, and all acute porphyrias can develop into this crisis. Triggers for development of an acute crisis are encountered in the period. Therefore, knowledge of these triggers and management of an acute crisis is mandatory. Non-acute porphyrias do not lead to a neurovisceral crisis. So our main focus in this presentation will be on acute porphyrias because they are the ones that pose a risk of a neurovisceral crisis. So this is the classification. We've got 4 different types of acute porphyrias. The first one is acute intermittent porphyria. The second is hereditary coproporphyria. The third one, and the commonest in South Africa, is varigate porphyria. The fourth one, and the rarest, is aminolevulinate dehydratase deficiency porphyria. I'm not going to dwell much on the non-acute ones because they do not lead to a neurovisceral crisis, which we fear the most in our department. In terms of physiology, heme is a metalloporphyrin which is synthesized mainly in the liver and bone marrow. It is found in hemoglobin, myoglobin, and all cytochrome enzyme. Remember, hemoglobin is made up of 4 globin chains, which are surrounded by heme molecules, and each heme molecule has a porphyrin ring and an ion in its center. So genetic defects cause deficiency of enzymes which participate in this pathway. So this is the pathway. 4 of these steps, there's 8 steps that occur in the heme biosynthetic pathway. 4 of these steps take place in the mitochondria, and 4 occur in the cytoplasm. So in the first step, which occurs in the mitochondrion, glycine combined with succinyl-CoA with the help of an enzyme known as aminolevulinic acid synthetase to produce aminolevulinic acid, which I will refer to as ALA for the rest of the presentation. Aminolevulinic acid will combine with another aminolevulinic acid with the help of an enzyme called aminolevulinic acid or ALA dehydratase to form porphobilinogen. Porphobilinogen is very important because for diagnosis of most of the acute porphyrias, we need to check its levels in urine. So it's quite important. Porphobilinogen will condense with 3 other porphobilinogen with 3 other porphobilinogens with the help of an enzyme known as hydroxymethylbilane synthase, also known as porphobilinogen deaminase, to form hydroxymethylbilane. Hydroxymethylbilane will be acted upon by an enzyme known as uroporphyrinogen 3 synthase to form uroporphyrinogen 3. Uroporphyrinogen 3 will then be acted upon by an enzyme known as uroporphyrinogen decarboxylase to form coproporphyrinogen. Coproporphyrinogen will be oxidized by an enzyme known as coproporphyrinogen oxidase to form protoporphyrinogen 9. Protoporphyrinogen 9 will be oxidized by protoporphyrinogen oxidase to form protoporphyrin 9. And then an enzyme known as ferrochelatase will incorporate ion into the center of protoporphyrin, leading to production of heme. Once heme is formed, it will have a negative feedback on the first step, or on the enzyme that's responsible for the first step. So it will have a negative feedback on synthase to prevent production of more heme. So on the right side of the diagram are porphyrias that result when there is deficiency of the enzymes. So like I've said, there is 4 acute porphyrias. Hello, Doc? Okay, so like I've said, there are 4 acute porphyrias which occur in the heme biosynthetic pathway. The first one is in the second step of the heme biosynthetic pathway. It's when there is deficiency of aldehyde enzyme, and the name of the porphyria is aldehyde deficiency porphyria. It's very rare. I think the last case that was reported was in the 1960s. So we're not going to dwell much on it in this presentation, and there is not much information that has been published on it. The second acute porphyria that develops is in the third step, and it's called acute intermittent porphyria. This one is quite a common one, and it is associated with a high risk of developing neurovisceral crisis should the patient be exposed to triggers. So this one is due to deficiency, to mutation in the genes that are responsible for production of hydroxymethyl synthase, which is also known as porphobilinogen deaminase. The third acute porphyria is in the 5th step. It's known as hereditary porphyria. It occurs when there is mutation in the genes that encode coproporphyrinogen oxidase. Hereditary coproporphyria is also rare as opposed to acute intermittent porphyria and varigate porphyria. It mainly presents with cutaneous symptoms. It really, even its acute crisis is well tolerated by patients, so I'm not going to dwell much on it as well. The last and the most important to us as South Africans is varigate porphyria, which occurs when there is deficiency of protoporphyrinogen oxidase. So patients with porphyria are usually asymptomatic. They may have mild cutaneous symptoms, but in most cases they are asymptomatic. But if they are exposed to a trigger, they may develop a neurovisceral crisis or an acute porphyria crisis. So what triggers usually do is they increase heme requirements. So when there is increased heme requirements, the negative feedback on synthase will be removed, and then there will be increased production of synthase, which leads to accumulation of intermediates before the enzyme defect. So in our institution, the main triggering factors is drugs that stimulate cytochrome enzymes, leading to increased heme requirements. So an acute crisis results from the accumulation of porphyrins in the prior to the defective enzyme. So this diagram just shows which step occur in the mitochondria and which step occur in the cytosol. So the first step, which needs to production of ALA, occurs in the mitochondria, and then the rest of the step until production of coproporphyrinogen will occur in the cytosol, and then everything will move back to the mitochondria until heme is produced. So, like we've said, there are 8 enzymes involved in heme biosynthesis. Except synthase, deficiency of any enzymes of any of the enzymes lead to a certain type of porphyria. Precipitating factors usually lead to increased heme requirement, e.g. by inducing cytochrome P450 enzymes. Then there will be increased flux in the pathway and accumulation of substrates before the enzyme defect, which leads to a neurovisceral crisis. In terms of acute intermittent porphyria, varigate porphyria, and hereditary coproporphyria are inherited in an autosomal dominant manner. This means even mutation in one copy of the gene. Mutation even in one copy of the gene is enough for the patient to develop the disease, whereas ALA dehydratase deficiency, porphyria, is inherited in an autosomal recessive manner. This means that both copies have to have the mutation for the patient to have the disease. This explains why it's so rare. The last case was discovered in the 1960s. This is because for it to be passed to offsprings, both parents need to be carriers. So acute intermittent porphyria is commonest in northern Sweden. It affects 1 in every 10,000 people. Variegate porphyria is commonest in South Africa. It mainly affects the the Afrikaner community. It affects mainly people of Dutch ancestry. It occurs in 1 in every 250 to 500 people. This is explained by a single point mutation which was discovered um, in 1688 in 2 Dutch settlers. So, as we've said, variegate porphyria is the commonest in South Africa. It affects mainly the Afrikaner community. Males and females are affected equally. Only 40% of these patients develop symptoms, and it's usually just cutaneous symptoms. So cutaneous manifestations affect mainly the sun-exposed areas of the body. It presents with photosensitivity. So patients with variegate porphyria may develop blisters once they are exposed to sunlight. They may develop scarring of the skin. They may also develop areas of necrosis as well as hyperpigmentation. These patients are at a very high risk of developing an acute neurovisceral crisis should they be exposed to triggers. So this is just a picture of a patient with the cutaneous manifestations of variegate porphyria. So as you can see, the patient has fluid-filled blisters. There is a hyperpigmentation of the skin, and there are also areas of necrosis. So that brings us to an acute attack or neurovisceral crisis, which we fear the most because it's basically what we try by all means to avoid in these patients. So it's said that the enzyme deficiencies that occur in porphyria are only partial. Reduction, there is only about 50% reduction in enzyme activity. But once porphyric patients are exposed to triggers, a neurovisceral crisis or acute porphyric attack can occur. So an acute attack is common in women who are in their 3rd or 4th decade of life. There are many postulated mechanisms by which triggers lead to an acute attack. The first one being interference with the negative feedback of allosynthetase by heme. The second is interference directly with heme synthetic pathway. The third one is induction. The third and the commonest in our department is induction of cytochrome P450, which leads to increased heme requirements. So this is just a flow diagram that I drew. It basically explains how the neurological dysfunction comes about during an acute porphyria attack. So there are two postulated mechanisms which lead to the neurological dysfunction during an acute attack. The first one is that increased ALA. Okay, is that aminolevulinic acid is neurotoxic, and we know aminolevulinic acid is increased in all forms of porphyria. So it's said to be neurotoxic. It crosses the blood-brain barrier and damages the neuronal as well as glial cells. It affects the central nervous system, leading to psychological symptoms mainly. There may be seizures and even coma. It also affects the peripheral nervous system. This explains the neuropathy that these patients may have during an acute attack. It also affects the autonomic nervous system, and this explains the GIT symptoms that these patients usually present with, as well as the cardiovascular system, the cardiovascular symptoms. The second postulated mechanism is that with decreased production of heme, there will be acute heme deficiency, and that causes neuronal damage. So these are the two main postulated mechanisms by which neurological dysfunction occurs during an acute attack. So there are several triggers that lead to an acute porphyria attack. Alcohol is said to be a trigger. Smoking is a trigger. Drugs can trigger an acute attack. We're going to dwell more on drugs that we need to avoid in our department a little bit later. Fasting is a trigger because decreased glucose stimulates the first step. It stimulates the enzyme that is responsible for the first step. Hypoglycemia stimulates synthase, so there will be increased flux of intermediates before the defective enzyme, which leads to an acute attack. Dehydration is also a trigger. Stress, be it physical or emotional, is a trigger of an acute attack. That's why, as part of our pre-op management, we need to make sure we alleviate anxiety in our patients. Infection is also a trigger. Hormonal changes also play a huge role in terms of triggering an acute attack. This is supported by the fact that pre-puberty acute porphyric attacks are very rare. It's also supported by the fact that acute attacks are very common in female patients who are in their luteal phase of the menstrual cycle. It's also supported by studies that have proven that some metabolites of testosterone and progesterone seem to have porphyrinogenic effects. So that brings us to the clinical features of an acute attack. So most of these patients present with abdominal pain. It's usually described as excruciating recurrent abdominal pain, which is poorly localized. It may be associated with nausea and vomiting. Constipation and diarrhea may also occur. In terms of the cardiovascular system, the patient may have tachycardia, hypertension, as well as tachyarrhythmias. These patients also develop muscle weakness, and the pattern in which it develops is it affects proximal muscles before and more than the distal muscles. So upper limb muscles will be affected before lower limb muscles, which makes Guillain-Barré syndrome a differential. Some of these patients may develop quadriparesis. 20% develop respiratory failure. There may be bulbar palsy as well, which is impaired functioning of glossopharyngeal, vagus, accessory, and hypoglossal nerve. So these patients are also at a very high risk of aspiration. In terms of psychiatric symptoms, patient may present with mood disturbances, with confusion, or psychotic features. Seizures may also occur. They may occur as a CNS manifestation, or they may be due to hyponatremia, which is very common in these patients. These patients also usually complain during an acute crisis of severe back pain, pain involving the thigh, or extremity pain. They may also have a sensory neuropathy over the trunk. In terms of electrolyte imbalances, these patients usually develop hyponatremia and hypomagnesemia. Hypokalemia may occur as well. Hyponatremia could be due to syndrome of inappropriate antidiuretic hormone secretion, or it could be due to increased secretion of and excretion of sodium. Cutaneous manifestations only occur in variegate as well as hereditary coproporphyria. So it's what we've explained. They develop vesicular rash as well as photosensitivity. In terms of diagnosis, we need to have a high index of suspicion in these patients because most patients with porphyria are asymptomatic. So we need to take a very detailed history. We need to take family history of porphyria, but this may not be helpful because most people are asymptomatic for the rest of their lives. For generations, the family may be asymptomatic. So if the case is so urgent, do any investigations, we need, and there's family history of porphyria, we need to treat that patient with an anesthetic, with an anesthetic technique that is appropriate for a porphyric patient. Porphobilinogen levels can be collected. So we need to take a fresh urine for porphobilinogen levels. But that sample needs to be protected from light because light is said to oxidize porphobilinogen, which may lead to false negative results. So if time permits, we can do lab investigations. If there's family history, we can do DNA analysis and demonstration of decreased enzyme activity. We can also do urine and fecal assays. Urine assays are mainly for aminolevulinic acid levels as well as porphobilinogen levels. And then from fecal assays, we can just check levels of porphyrins. So porphobilinogen, okay, normal porphobilinogen rules out acute intermittent porphyria, variegate porphyria, and hereditary coproporphyria, but it does not rule out alert dehydratase deficiency anemia. Porphyria. Remember, alert dehydratase deficiency porphyria results from a defect before production of porphobilinogen, so it will not be increased in it. So in variegate porphyria, which is very common in South Africa, the mutation is in the protoporphyrinogen oxidase gene. So we can take EDTA blood for DNA protoporphyrinogen oxidase R59W mutation. Protoporphyrinogen oxidase deficiency can also be seen in fibroblasts and lymphocytes. We should also take urine and fecal assays. This is a very dangerous form of porphyria because these patients can develop hepatocellular carcinoma and renal failure at a later stage. In acute intermittent porphyria, the mutation is in the long arm of chromosome 11 at hydroxymethylbilane gene. Porphobilinogen deaminase deficiency can also be seen in erythrocytes. So we need to also do urine and fecal testing and protect our urine from sunlight. In terms of the differential diagnosis, we need to rule out surgical causes of acute abdomen. The main difference between the severe abdominal pain that porphyric patients present with and surgical causes of acute abdomen is absence of peritonism in porphyric patients. So in porphyric patients, as much as they have this excruciating abdominal pain on examination, they are not peritonitic. We need to rule out pheochromocytoma, which is also a differential. Guillain-Barré syndrome is also a big differential, especially when they present with that paresis, which affects proximal muscles before distal muscles. We need to rule out delirium if they present with the psychiatric features. If they have seizures, we need to rule out epilepsy. We need to rule out hypertensive emergency and tachyarrhythmias in these patients. So in terms of management of an acute attack or neurovisceral crisis, there are general measures, supportive measures, as well as heme hygienate. General measures and supportive measures usually suffice in managing patients with an acute attack, but if the patient still is symptomatic, then we may need to go to heme hygienate. So in terms of general measures, we need to review our drugs. We need to stop any drugs that are known as triggers. But if in the case of a life-threatening condition, emergency drugs should not be delayed over fear of their safety. Carbohydrate energy supplements play a very huge role in these patients because glucose is said to inhibit synthase activity. So it will lead to alleviation. It will alleviate symptoms that are associated with the neurovisceral crisis. So we can give our carbohydrate supplements orally or via an NG tube. If that's not doable, we can give IV 10% dextrosaline infusion, aiming for a total of 200 kilocalories in 24 hours. The reason why we combine our dextrose with normal saline is because these patients are at a very high risk of developing hyponatremia and seizures. And seizures combined with the very high risk of aspiration may kill the patient. So we need to avoid hyponatremia as much as we can. In terms of supportive management for abdominal pain, we can give high doses of morphine and pethidine. We can give 50 to 100 milligrams of pethidine every hourly until there is relief of symptoms. We're not really worried about a dependence because the high doses are for a very severe pain. So chances of the patient developing a dependence or tolerance are very low. For nausea and vomiting, we can give a prochlorperazine or use ondansetron with caution. We need to alleviate anxiety in this patient because, as we've said, stress is one of the triggers of an acute attack. So if our patient is anxious, it may worsen everything, or it may even trigger an attack on its own. So most of our benzos are not contraindicated in patients. We can use lorazepam, we can use midazolam. So for the psychiatric features, we can use haloperidol or chlorpromazine. To arrest seizures, we can give. We need to correct hyponatremia. We can give clonazepam, gabapentin, or diazepam. Beta blockers can be used for tachycardia and hypertension that these patients can present with during an acute attack. And then if our patient has neuropathy, as well as a severe, if there's severe muscle weakness and we're worried about aspiration, we may need to intubate and ventilate our patient. So heme is a very important agent. Different studies say different things. Some studies say because of how expensive it is, we need to wait for 24 hours. And if there is no response from the general measures as well as the supportive treatment, then we may need to start heme. Some studies say it needs to be started as soon as possible during a neurovisceral crisis. So it replenishes heme stores. It also inhibits hepatic aminolevulinic acid synthase, leading to reduced ALA immediately. The dose is 3 milligrams per kg per day. IVI, it needs to be given for 4 days. The main problem with heme is phlebitis. So we need to administer it with 100 mils of 20% human albumin, which will act as a buffer. And it should be given over 20 to 30 minutes in a large vein, if you can. It's a very expensive drug. I think that the cost for 4 vials, which will be used for 4 days in one patient, is about 20,000 rands. So it should be used when the other measures are not helping. That brings us to the anesthesia considerations. So the mainstay of safe anesthetic management in porphyric patients is identification of susceptible individuals or individuals who are at risk of a neurovisceral crisis, as well as knowledge of agents that are porphyrinogenic. So we need to take full history from every patient. We need to take family history in patients who are at high risk of developing porphyria. We need to do thorough physical exam. We need to rule out autonomic instability on physical exam. We need to rule out peripheral neuropathy on physical exam. We need to to look out for tachycardia and hypertension in the cardiovascular system. In the respiratory system, we need to rule out any respiratory muscle, any signs of respiratory muscle paralysis. So we need to check for muscle strength in these patients, as well as functioning of the cranial.
Please, Lila, can you go fast because you've already have 30 minutes.
Okay, all
The
right.
time is really not on our side. Okay.
Okay, so we need to do a thorough physical exam. And then in terms of safety of the drugs, safety of drugs is based on what is called anecdotal experience. This basically means that it's based on experiences with certain drugs. So there's not really a study that was carried out, uh, a formal study that was carried out. So drugs can be labeled as use with caution, use with extreme caution, or avoid. If the drug is labeled as use, it means that drug has been used safely and you can use it. If the drug is labeled as use with caution, it means as much as its safety cannot be proven beyond reasonable doubt, there is evidence shows that it's unlikely to be unsafe in clinical practice. If it's labeled use with extreme caution, it means that evidence shows that the drug may be unsafe in clinical practice. If it's labeled as avoid, it means that the drug has triggered acute attacks in humans and it should be avoided, completely avoided. So in terms of regional anesthesia, central and peripheral nerve blocks can be done with bupivacaine. They can be safely done with bupivacaine. And neurovisceral anesthesia is also not contraindicated, but you need to do a thorough physical exam to rule out autonomic instability, neuropathy, and hemodynamic instability. With regards to GA, preoperatively, we need to avoid prolonged fasting. If it cannot be avoided, we need to make sure we give dextrosaline during fasting. We need to alleviate anxiety, and if there is need for antacids, we can use sodium citrate safely. So in terms of inhalational agents, nitrous and halothane are said to be the safest and can be used. Isoflurane has been safely used in some cases, but there are not too many studies that have been done with it. So it needs to be used with caution. Sevoflurane and desflurane have also not been properly studied. Um, so they need to be used with caution, but they are short duration of action and minimal metabolism increases likelihood of them being safe drugs. In terms of IV induction agents, propofol is the safest and can be used freely. Ketamine has been used in many cases without any problems, but some animal studies have shown increased levels of ALA and propopilinogene in patients who in patients who've been given ketamine. So it should be used with caution. Etomidate has induced acute attacks in human beings, and animal studies show it to be a trigger of a porphyrinogenic agent, so it needs to be avoided. Sodium thiopentone needs to be avoided because barbiturates are cytochrome P450 stimulators. In terms of analgesic agents, acetaminophen, aspirin, morphine, codeine, fentanyl, sufentanil, and alfentanil are safe and can be used. Diclofenac, ketorolac, and tilidine, which we call Valoron drops, should be used with extreme caution. In terms of neuromuscular blocking agents, scoline has been used many times without any problems, so it's a safe drug and can be used. Rocuronium should be used with caution because it has not been properly studied. Pencuronium and alcuronium should be used with caution. Some authors say they are porphyrinogenic, but some doctors have used them without any problems. Atracurium and vicuronium are said to be safe, but some people have witnessed acute attacks with their use, so they should be used with caution. All our reversal agents are safe and should be used. In terms of local anesthetics, anesthetic drugs, bupivacaine is safe and can be used. Lidocaine is safe. Ropivacaine should be avoided. With the cardiovascular drugs, epinephrine is safe. Alpha agonists should be used. Beta blockers, beta agonists should be used. Verapamil and diltiazem should be used with caution. Hydralazine and nifedipine should be used with extreme caution. In terms of our antiemetic drugs, metoclopramide and ondansetron should be used with caution. Prochlorpromazine can be used safely. In terms of antibiotics, aminoglycosides such as gentamicin can be used safely. Penicillin and cephalosporins can be used. Imipenems and vancomycin can be used. Macrolides, for instance, erythromycin, sulfonamides, quinolones, and fragile needs to be avoided. Synthosinone, carboprost, and tranexamic acid can be safely used. Thank you.